Hello. Hi, good morning, good afternoon. Welcome to our latest ARC Talks webinar, which is on GI disturbances and symptom management with amyloidosis. I will just give a brief introduction about ARC, which is the Amyloidosis Research Consortium. Our vision is to make a significant impact on the curability of amyloidosis. We do this through collaborative initiatives and innovation to advance the science, both to improve treatments and also extend the lives of those with amyloidosis. We're patient-founded, patient-focused nonprofit determined to shift the paradigm. We have 4 areas that we focus in: improving the speed and accuracy of diagnosis, which is critical for patients to benefit from the treatments; increasing the understanding of the science behind the disease; accelerating regulatory approval, and also the reimbursement of effective new treatments as they come to market for patients; and enhancing care and quality of life of patients and caregivers throughout their entire journey with amyloidosis. ARC Talks fits nicely into that 4th bucket. I'd like to thank the sponsors of today's webinar. And on that note, I'd like to introduce, and actually just before I hand over, we will have time at the end of the talk for questions and answers. There is a Q&A little button that you can hit and type your questions in. So please do so as you think of them and as they arise, and then we'll deal with those at the end. So feel free to do that. So without further ado, I am delighted to introduce Dr. Horst today, who is a professor of medicine in the Division of Gastroenterology, Hepatology and Nutrition at Vanderbilt University Medical Center. She's involved in the clinical care of complex IBD care, complex amyloid patients care, clinical research, and teaching and mentoring medical students. She is part of their multidisciplinary amyloidosis team and has over a decade of experience in treating amyloidosis patients. So welcome and thank you for joining us today. And I will stop sharing and hand over to you.
Wonderful. Thank you so much. I'm going to share my screen. Hopefully I get this correct. All right. I'm really excited to be here today. Putting this presentation together reminds me that I've had the honor and privilege of taking care of patients who have amyloidosis on the multidisciplinary amyloid team here at Vanderbilt for over a decade. It has seen a lot of different patients with a lot of different presentations of amyloidosis. So probably what you'll hear the most through this presentation is that your experience or your family members or your partners or your friends' experience with amyloidosis as far as GI symptoms are concerned are going to be their own and a little bit different for everyone. But hopefully I'll sort of help you understand how I think about taking care of the symptoms, and we can have some question and answer at the end as well. So, I think you all are very probably aware of amyloidosis and how it affects you, but I think one of the things that I think about when I'm thinking about a patient that I just meet is what type of amyloid do they have? And it's really important because obviously these are going to be treated very differently. And when I think about amyloidosis in the GI tract, most of the time it's systemic, right? Patients have AL amyloidosis, or they have familial or non-AL amyloidosis, or very rarely AA from chronic disease. But I'm probably like the one organ system where I've found a few patients and take care of a few patients who just have amyloidosis in their GI tract and it doesn't show up anywhere else. So this is something that is rare, but it can occur, and we'll talk about that a little bit. So here's the deal with amyloidosis, as with everything, every other organ system, right? It can affect everything. It can affect the mouth, and some patients can get really significant macroglossia, which means their tongue gets really big and can inhibit eating. And some patients need assistance with feeding tubes and things like that to be able to get nutrition. It can affect the GI tract from the esophagus to the stomach, to the small bowel, to the colon. It can affect the liver. And with that, all different sorts of manifestations can occur. People can present with GI bleeding. They can just have low blood counts. They can have heartburn. They feel like they can't eat. They throw up. Sometimes it causes slow GI tract, and sometimes it causes fast GI tract motility. And patients can end up with really severe diarrhea, but not all the time. It can cause severe constipation. So again, this is what I'm saying, sort of everyone's experience with their GI tract and the effect that amyloid can have is very personal and different. And some people have no symptoms. So it's just all over the place. Again, this is just sort of a different look at what's happening here. And one thing I wanted to highlight is what I've seen. So I've taken care of, at this point, probably over 100 patients with amyloidosis. And probably the thing I've seen the most is dysmotility. So your GI tract, when you think about your GI tract, it has almost as many nerves as your brain, right? This is a really complex system that's trying to move your food from your mouth through your esophagus, your stomach, your small intestine, your colon, and out the other end, right? But this is a really complex motility that you don't even think about. It happens every day until it doesn't work right. And so because of this, the nerves of the GI tract can get affected. And this is what I've seen be the biggest burden to patients, is that this lovely, complex movement that we don't think about every day, getting our food through, doesn't work the way it should. And this can cause lots of different symptoms for patients. Importantly, radiologic studies, so like a CT scan and things, most of the time are normal. Sometimes it can, and if it's really severe, especially in the stomach, it can show that food just sits in the stomach, or the radiographic study that we do shows that food just sits there, or the esophagus doesn't squeeze like it should. Sometimes we see things go really quickly through the small intestine, but most of the time, radiologic studies are going to be pretty normal. Every once in a while, we'll see thickened parts of the GI tract, but most of it's normal. If we can catch anything abnormal, it could be in functional studies. So we have this really fancy thing called esophageal manometry. It's like not the most fun test to have, but they can put this like tube down your nose and then you swallow things, and it can show how your esophagus, which is supposed to squeeze nicely, can just sort of do this. Anorectal manometry. So even, this is a complex thing to get your stool, your poop out of your bottom. And there are two sphincters, and those can actually get affected by amyloidosis as well, the nerves. And so this can cause dysfunction, and it could cause a lot of motility issues. So even though a lot of times these things are normal, sometimes doing these functional studies can be helpful for a gastroenterologist to help understand why you're having the symptoms you're having. Again, endoscopy. So this is where we put the scope down into you, like from an upper scope, like an esophagus, looking in your esophagus, stomach, or small intestine, or your colonoscopy, which everyone should have at age 45 or up. But if you have amyloidosis, we may be looking. Sometimes it's abnormal. We can see ulcers, we can see masses, we can see nodules. Most of the time it looks normal. So I could put the scope in and it looks normal. But sometimes people have pretty significant bleeding, and we may need to intervene on that. That's pretty rare. I think importantly, I will often do biopsies, and we're going to go into this a little bit more, but a lot of times those biopsies are negative, because remember what I just talked about. Amyloidosis often affects the nerves of the gut. Well, that's not something I can biopsy. That sort of sits behind the mucosa. It sits back a little bit more outside the GI tract. And so I can't really biopsy that. So I really do have to rely more on symptoms and how people are feeling. The nerves of the gut, we can't really see so much. If we see amyloidosis deposit in the GI tract, it's really going to be in the blood vessels, and that doesn't always happen. It is really important to send these biopsies off for special typing to make sure we understand what sort of amyloidosis this is. I have definitely seen patients who've come to me without that. So that's something really important for us to do. And then again, it's really, we've got to do all this testing. So if someone comes to us with they had a polyp taken off and my goodness, amyloidosis was found, we'll really need to do that extensive workup to ensure that no other organ systems are involved. But there are really rare cases where it's really limited to the GI tract. And this is one study that was published a while ago, but it looked at Boston University, and they found of 76 patients, 21% actually just had, and this was if they had been diagnosed through their GI tract, 21% just ended up having this in their GI tract only, couldn't find it anywhere else. And none of these patients progressed to have any other systemic disease. So it's rare, but I've had a few patients like this, and we just watch and make sure that nothing progresses. And depending on the type of amyloid will depend on what sort of follow-up the patient needs. But this does happen, although rare. Again, so, you know, it's really important. I spend most of my time when I talk to patients in clinic helping them understand that probably a lot, if they're having a lot of GI symptoms, it's really probably because the nerves of their gut are affected. And so sometimes we won't find the amyloidosis of the gut on a biopsy. It doesn't mean that it's not affecting the GI tract. And so really my job on the amyloidosis multidisciplinary team is less directing the type of treatment for the amyloidosis and more just trying to treat the symptoms. So my job on the team is really trying to make those GI symptoms, if present, better. And the other members of the team, depending on what it is, if it's AL amyloidosis, you know, really focusing on treatment for that, or if it's, you know, familial or non-AL, managing that, those sort of treatment strategies, of which have exploded since I started in the on the team, which is really exciting. But I tend to do a little less of that management and just trying to help with symptoms. So with that, I'm going to talk a little bit about some data that we found at Vanderbilt. So this was presented a while ago, back in 2018, but you can see that even back then, I'd seen in my clinic 91 patients, many of who had AL amyloidosis, but also had different sorts. And biopsy proven GI amyloidosis was only found in 43% of those patients. But a lot had symptoms, and you can see how many, there's all sorts: constipation, diarrhea, nausea, early satiety, heartburn, weight loss, bloating. Patients could have more than one of these, but you can see lots of different types of presentations. What I found was pretty important was that patients who had biopsy proven, the most likely spot for me to find it, if I was going to find it, was actually in the upper GI tract. So in the stomach, the esophagus, or the duodenum. And biopsying the colon actually only found positivity about 27% of the time. And it was more likely to be found in patients who had AL amyloidosis than patients who had non-AL amyloidosis, even though non-AL amyloidosis had just as many GI symptoms. So it may be that non-AL amyloidosis really just affects the nerves of the gut, and we're just going to see it less in the blood vessels on biopsy. So I think this is what I talk to patients about and help them understand that you may have these symptoms that could be from amyloidosis. Just because we're biopsy negative doesn't mean that you're not experiencing it from amyloid. Now, one important thing is, so it may be negative. If it's positive, so say we find it in your gut, if those amyloid deposits are present in the blood vessels of the gut, they can remain there for years. So biopsy persistence in the GI tract, to me, is not really typically significant. If patients are in remission in every other area and they've gone through treatment, even if they have a little bit of this persisting in the blood vessels of the gut, it doesn't mean that the amyloidosis is not being treated adequately. So I think that's another important point to kind of think about and remember. All right, so let's think a little bit about treatment. And Overall, treating the underlying cause, trying to prevent further amyloid deposition, getting that under control is the most important thing. And that's a little bit outside of my purview, right? Like that, we're going to have the hematologists or the neurology team or the cardiology team really be sort of driving the treatment. But that's really important, because what I've seen in just sort of treating patients over the years is, say someone has AL amyloidosis and they start chemotherapy, actually see those GI symptoms improve over time. And we don't really completely understand that, because sort of classically, you think when nerves get affected, they sort of, there's no improvement of that. Like that's sort of the classic thinking, but I've definitely not seen that. I've seen patients who are treated for their underlying AL amyloidosis get into remission and these GI symptoms improve. And it could be that we're just preventing further deposition and these nerves are not getting affected as much. I don't think we completely understand that, but the good news is I see things get better. So I hope that's helpful to hear and think about. But second, this is where I come in and I try as much as I can to help patients who get treated symptomatically. So I'm going to kind of go through the GI tract, because how patients are affected really is what sort of symptoms they have will depend on what I try to do as far as treatment strategies are concerned. So some patients may have reflux, nausea, vomiting, and early satiety, and that's probably because their esophagus is not squeezing the way it should. Or more often what happens, and this is sort of the way that I talk about it to patients to help frame things, is that your stomach is like this sort of a bag, and it's supposed to squeeze really hard. It's to churn things around and squeeze it out to get to your small bowel. Well, what happens in amyloidosis is a lot of times the bag just sort of half squeezes. Things don't empty out as well, and you don't feel like eating, or food just sort of sits there. And so because of that, and that happens a lot, and then the part that really stinks is that your small bowel probably moves too fast. So then you've got your stomach that's sort of sitting there, and your small bowel that moves way too fast. So you don't want to eat, and then you get diarrhea. And that's sort of a classic thing that I've seen. So what some of the things that we'll try to do to help with this is to minimize acid in the stomach, so that if food is sitting there and you start to get reflux or nausea can happen if you have reflux type symptoms, is we'll use proton pump inhibitors a lot. And that's to decrease the acid production in the stomach, so you have less of those heartburn or nausea symptoms. Sometimes if the slow stomach is really bad, we actually have to use prokinetic agents. There's not a lot of them, but there's a few that can help the stomach, that bag, squeeze a little bit more. And that can help. Now, these can come with side effects that can be pretty significant. So I talk through, I have a discussion with the patient about risks and benefits of these to really help them understand. Metoclopramide in particular can have a rare neurologic side effect of a Parkinson's-like thing. It's super rare, but it can happen. So we just have to talk through the risks and benefits for that. Treating small bowel bacterial overgrowth is something you're going to hear me talk about a whole bunch over the next few minutes. And this is sort of the mainstay. This is something that I try most of the time for most patients to start. Because what I find that happens is that patients who have amyloidosis, and I'll talk a little bit about this more in just a slide or two, are really prone to small bowel bacterial overgrowth. And so treating that with antibiotics, I find, can be very effective. Treating with antiemetics, so making you feel not nauseous or try to prevent vomiting, is super important. So things like ondansetron or promethazine, these are things that are anti-nausea medicines, can help. If the stomach is really slow, sometimes we actually have to help you eat differently to try to help with that. And I have some quite a few slides at the end, actually, that I got from my amazing dietitian team to help through that. Sometimes patients need feeding tubes, or even being fed through their vein, called total parenteral nutrition. That's pretty rare, But some patients need that to help them overcome these motility issues. And we've definitely had patients who've had to go through that and have had help with that. Okay, so diarrhea can be a big problem. And what I'll hear most of the time is this happens after I eat. I eat a big meal, and 30 minutes later, I have a terrible diarrhea. Well, that is probably so we all normally have that. So patients without amyloidosis who don't have dysmotility or problems, we have a normal stimulatory pattern to make our bowels move. It's called the migratory motor complex, or MMC. It's stimulated by eating. So what happens is you eat, things move in your stomach a little bit, then your small bowel is like, whoa, it's my job. So it's supposed to do this really fancy squeezing thing. Your small bowel is really long, and this is where you're supposed to absorb all your nutrients. So it's supposed to be doing this thing where it's like moving all your food through. Well, what happens if the nerves of the small bowel get screwed up is they can lead to dumping. So instead of doing this we call it peristalsis, your small bowel will just say, oh, here it is. And the whole thing squeezes and the whole thing lets up. And when that huge squeeze happens, instead of the peristalsis, you can dump. And so you can have a bunch of diarrhea after you eat. The other problem that happens is when you sort of have this big old dump and then small bowel just sitting there, is you can get what we call small bowel bacterial overgrowth. Your bowels have so much bacteria, and it's really to aid digestion. And unfortunately, our Western diet and probably a lot of the additives and things that go in our food begets sort of bad bacteria. That's not really bad, but it's an overgrowth of this bacteria that causes a lot of gas, and it causes your body to not be able to break down simple sugars the way it should. When that happens, your body can't resorb water. All that stuff sits in your bowel, and all of a sudden you have diarrhea. So the goal of small bowel bacterial overgrowth treatment is to try to get you back to the right bacteria, the good mix. And I use antibiotics all the time for most symptoms, early satiety, nausea, diarrhea, bloating, which is a huge problem for a lot of patients. And I'll talk to you about the antibiotics that I use, but I really like rifaximin. It's one that I use a lot. So I sort of go through that first. Antidiarrheal agents are really important because we're trying to dampen down that big, huge migratory complex that's happening. What I want people to do is actually stop it before you eat. So a lot of times I ask patients to take loperamide or Lomotil. Loperamide's over the counter, that's Imodium, or Lomotil. And they take that 30 minutes before they eat that big meal because we're trying to damp down that big old migratory motor complex. And patients can do this a lot. So a lot of times patients come to me, they're like, oh, Imodium doesn't work. Well, how much are you taking? You can take up to 12 pills a day if we need to, obviously with close monitoring. But a lot of times people just need more because we're trying to really overcome this dysmotility and nerve damage. If that doesn't work, sometimes we need to treat bile acid abnormalities. So bile acid comes out of your gallbladder and actually helps break a bunch of your food down. But if you've had a gallbladder removed, all those bile acids are just dumping right into your GI tract. And if you may have already been able to overcome this for years, but now if you have dysmotility, you may not be able to overcome that. And so we actually give you bile acid binding agents to help. And I usually start those pretty slow and titrate them up. They can cause bloating, so that's kind of a big side effect. Rarely patients get pancreatic insufficiency because their pancreas can get infiltrated with amyloidosis. And super rarely I've used some really heavy duty medications to help with diarrhea called octreotide, but that's pretty rare. So this is just a little bit of data that we presented again back in 2018 because I was seeing so much improvement with treatment of small bowel bacterial overgrowth. And I thought, man, it seems like rifaximin works better than the other antibiotics that I've used. And you can see here, when we looked at resolution of symptoms after antibiotic treatment, it was much higher with rifaximin than some of these other antibiotics. So this is the one that I go to first. Now, rifaximin is a super safe antibiotic. It really doesn't absorb into your body. So your body really doesn't like it doesn't cause, antibiotic resistance or anything, because it's really just working in the gut and trying to reset these small bowel bacteria. I actually use it. It's approved for IBS diarrhea at a dose of 550 milligrams 3 times daily for 14 days. I actually use it at a little bit of a lower dose. A lot of patients just need it twice daily. They often need it for 7 days. Here's the problem with small bowel bacterial overgrowth. Treating it once makes it go away for a while, but it tends to come right back. Unfortunately, probably partly our diets and who knows what. We don't think we completely understand this. But a lot of times my patients need retreatment, even up to once a month, to help with their symptoms. And again, I used it for early satiety, bloating. I mean, bloating is the big one, but diarrhea is the big one. But I've used it for nausea, early satiety, and really found improvement. I don't really test for small bowel bacterial overgrowth. I just try to treat it. So that's sort of my treatment strategy. Constipation is a big problem, actually. A lot of patients with amyloidosis come to me with worsening. They may have already sort of had slow motility, and this has just worsened it. So I spend a fair amount of time talking about constipation to amyloid patients, which may not classically be thought of. A lot of people think, oh, they just have diarrhea. No, actually, constipation can be a big problem. Miralax is sort of the mainstay. And then often I'll use like a stool softener or Colace. Sometimes I'll use a pro-motility agent like Dulcolax, but that can cause cramping. So I usually try to use something a little softer first. And actually, there's tons of anti-constipation meds out now. There is linaclotide, there's lubiprostone, there's other medicines. So I actually use a lot of this in my clinical practice as well to sort of help with this dysmotility, and have found great success. A lot of patients have had good treatment. So I wouldn't be hesitant to use these if this is something, if you have constipation that's just not being well managed by over-the-counter. There's a lot of options, and we use it. We call it irritable bowel syndrome, constipation type. I do think it's probably amyloidosis having an effect, but I've found these to be really helpful. Patients can have significant GI bleeding. If that's the case, sometimes we've had to do endoscopic therapy, even surgery. Some patients, it just is through the whole GI tract and they just bleed, and they need supportive care with blood transfusions or iron. Malnutrition can be a really big problem. And I'm going to talk a little bit about diet, or a lot about diet, actually. And it really depends. It's all over the place. Some people get malnutrition because they can't eat because of their large tongue, or they can't eat because their stomach won't empty, or they are losing weight because of their protein losing enteropathy from diarrhea, or they just are so constipated they can't eat. So lots of things that we do. So really trying to treat the underlying cause, doing a lot of dietary intervention we've found to be helpful. And some patients end up needing feeding tubes or even surgery, but that's pretty rare. All right, so I'm going to spend probably the last 10 to 15 minutes, and we can, I put a lot of information that I got from my dietitians who have been immensely helpful in trying to help with diet interventions, because I think this is really important, because your diet depends on your symptoms, right? So if you have gastroparesis symptoms, like your stomach's not empty, you're going to need a low fat, low fiber diet, and you're need to eat lots of frequent meals per day. If you have terrible diarrhea symptoms, you probably need high soluble, low insoluble fiber diet to try to help with lots of water to try to help manage any dehydration. If you're having weight loss, you need high protein and high calorie, high fat diet. So all of these are really different, right? I think it's really important for us to understand that patients feel better when they are eating clean, whole foods. We don't spend enough time talking about it. Food can be medicine. And if you're not having a lot of GI symptoms, or you've been able to manage this, a Mediterranean diet is a great start. We all should be doing it. I should be doing it more, it can be difficult when we are inundated with Western diet and maybe less healthy and processed food diets, but it's really important. It can be helpful. We have dietitians. We actually have here at Vanderbilt, we have a functional medicine team who does even more intervention around this, also does tries to help with lifestyle and stress interventions as well. So some of my patients even go through a more formal functional medicine type education. But let's think about this. So this is just sort of that Mediterranean diet, right? I think about every day I try to do better about eating the rainbow, you know, like I'm trying to eat red, orange, yellow, green, purple foods. It's so, I mean, not Doritos, right? Not that kind of orange, but carrots or things like that. Choose grains really carefully. This can be really helpful. And then the protein that we eat could be from lean meats, seafood, beans, if possible, poultry, eggs, if you can, fat-free, low milk can be really helpful, Greek yogurt. And then using the different kinds of oils and fat up to 5 times a day can be really helpful. That actually can give you really good fatty acids that are good for you. And trying to stay away from things with a lot of added sugar and saturated fats. I'm not going to go through all of this. This will be available on the website, but I thought this is just so great to sort of give you ideas of like things I should choose versus things I should probably stay away from. With a lot of refined sugar and things like that probably aren't the best things. I mean, we want you to be happy and be able to eat a little bit, but things that you're going to put in your staple and things you're going to be eating every day should be things like whole wheat and whole grain breads. These are the sort of the proteins that we just talked about, but seafoods, fatty fish is really helpful for people trying to gain weight. You need good fat in your life, not just protein if you're trying to gain weight. And so this can be really helpful. Eggs, the sort of things that you need to think about are not, you know, tons of red meat, probably really fatty red meat, probably not the way to go. Tons of bacon, I know, but probably not. Fried fish, fried meats are probably not something that you should be having as a staple. Low Greek yogurt, so helpful for patients who can't tolerate a lot of lactose, but this has really good fat and good protein. So I talk a lot about that, cottage cheese. And maybe if you can't tolerate, you know, a ton of homemade milk, maybe that's something to avoid. And then all the vegetables we can eat, right? This should be something that we should all do. I need to do better about it every day. But again, these are things to sort of think about, try to get in the diet. I'm not going to go through all of this. I think I can skip through that. But again, I think you've heard me talk about when you are trying to gain weight, high calorie, high fat, and high protein is really helpful. And so these are some things, you know, trying to drink milk with soy, adding mixed dried fruits. A smoothie is so helpful for people who have trouble getting food and you know, that early satiety where you feel like you can't eat. Smoothies that you can sip on that have Greek yogurt and egg white protein powder and bananas and, you know, and peanut butter, that can be so helpful to get you the nutrition that you need. I've told patients, like if they're having weight loss, I'll write you a prescription. Your food, gaining weight is like your medicine. And so really trying to advocate and think in your brain, like I have to do this just like I need to take my medicine is so important. And a lot of this details in the PowerPoint, but, you know, trying to think about how you can saute things in olive oil or canola oil. That's really good fat. Adding olive oil or margarine or butter to things to just try to get you some more calories can be really helpful. Avocados have so much good fat. So that's another thing that I try to get people to eat if you can. And then fatty fish. Here are some snack ideas. Again, you can see Greek yogurts. You can see that a lot in here. Peanut butter is really, really helpful, and trail mix as well. Here's some more ideas that you guys can take a look at, and will be in the PowerPoint available. And then some people just need supplements, and this isn't a failure of eating. This is not, you know, some people, the best way to get their nutrition in is through supplements. And so here are some things that my dietitians recommend: boost high protein, Orgain, Ripple protein shakes. There's unflavored protein powders that you can add. There's flavored protein powders that you can add. Some are plant-based, which can be really helpful for people who are vegetarian, and just some simple ways to try to get some of this, some more protein available. So again, amyloidosis can affect the entire GI tract, and everybody's going to have a different experience. And so really treating the underlying cause is what's important. And symptomatic treatment can be very helpful. Dietary changes can be really important. It doesn't work for everyone, but I think at least an attempt is really important. And I really do want to thank my dietitian, Julia Carlson, who spends a lot of time with my patients, and is an immense resource for me. So with that, I will end, and I'm sure we'll probably have some questions.
Thank you. That was excellent. I loved in the beginning how you described the uniqueness of everyone. I think that's something we all experience and can make it even more isolating as a patient, that there isn't any standard course necessarily that this disease will follow. And also just the complexity that patients experience, having different recommendations with, you know, if they have cardiac issues or edema and needing to be on low sodium, but and different requirements. I think that working with the dietitian and having the GI physician as part of that is so important. So it's really wonderful to hear your talk. So I will move over now to the questions. And we have quite a few up here already.
Oh, good.
So one was that if you're a patient that's being prescribed Vyndamax, so for ATTR with wild type, can that help with GI symptoms?
You know, that is a great question. And to me, my experience is a little less robust because these are newer. So I've seen a few less patients. To be honest, I've seen less dramatic improvement. I think it's good. I think being on these medications can help, like anything we can do to help prevent deposition of amyloid protein to the nerves of the gut is really important. I haven't seen a dramatic change with them. So I think for me, it's more about prevention of worsening symptoms than likely a ton of improvement. Now, everybody's different, and I have had a few patients that felt a lot better, but it's been a little less overall dramatic, if that makes sense.
Yeah, absolutely. And there's a question around, can diet affect long-term for AL patients? Can actually, and we have this as often asked quite a lot at ARC, given that it's a protein that's misfolding, should you be concerned about the level of amount of protein you eat? Could that cause more amyloid deposition?
That's a great question, and not really. No, I mean, your body breaks down the proteins that you're ingesting. Like your stomach has a pH of 2, right? So it's breaking these all down, and really taking out the amino acids and things like that that it cares about and needs. So it really shouldn't affect how much amyloid would get deposited later on, because that's happening in your liver or for AL a little bit differently. So that shouldn't really affect it. And really, does it affect your prognosis? I don't know that we have any data for that really, but I think I think eating healthy is really important for other things, cardioprotection, weight management. So just to help you later in life as you're going along, eating this the best you can do. And I'm going to tell you right now that I fail it every day. So, the small incremental changes can be really helpful in what you should be doing over time.
Excellent. There are a couple of questions about constipation and how long should you wait if you haven't had a bowel movement before you act. And another one was asking, with patients, it can be so severe that it's called obstipation, which is not a term I'd heard before. And low fiber diet may be problematic. If gastrophoresis, what about low dose promobility agents on prescriptions such as motegrity? Is that something that should be used?
Yeah, so those are great questions, and probably really, how many bowel movements you should have per week is really dependent on you. Like if you tend to have, some people feel fine and have 2 bowel movements per week, and that's fine. That's okay. It's how you feel, and what sort of your baseline motility is. Now, if before amyloid, you were once a day, like clockwork, and since you've had this diagnosis, your motility is slowed down and you're going once a week and you feel terribly bloated and you're not eating, that needs to be treated, and you need to be aggressive about how you get your bowel movements increased. Now, how you do that, again, really dependent on the patient. What's really interesting about these pro-motility, sort of the anti-constipation medications, and some are more pro-motility. So motegrity, for instance, if someone had really terrible gastroparesis and terrible constipation, motegrity is really pro-motility. It's the one that is one that we use sometimes. But I've had some patients who Linzess works great, and they had really bad gastroparesis and they also had constipation, and I put them on this, and that really is a sodium channel. So it's just getting more water into the colon. It's not really making things move better, but they felt much better, gained weight, could eat, so it really is dependent on the patient. And I've had many different experiences with lots of these agents.
Interesting. We have a question here, which is concerned about the patient who has both cardiac and GI issues and had questions about the use of Imodium. Should they be worrying about it with cardiac side effects?
No, I mean, if that's a concern, definitely talk to your cardiologist and work with your gastroenterologist as well. But I've never had any problems with that or any concerns from my cardiologist about that use. I mean, I think if you're using, if you're needing it a whole bunch, maybe there are other treatment strategies that you might need to be thinking about a little bit more. Like, should you be trying rifaximin, or should you be trying a bile acid binding agent or something like that to assist?
And what about the use of Ozempic? Is there any impact on amyloidosis or other treatments? Is that safe to use?
That is a great question, and I'm not sure I have all the complete answers about how it would affect amyloidosis, but I can tell you from a GI tract standpoint, Ozempic, all of these drugs, which are fantastic and are helping with weight loss and reducing cardiac risk and I think saving people's lives, it slows your gut down. It just does. So if you have problems with slow motility, you may have big problems with trying to do a GLP-1. You might be fine, but I think that's something I've definitely had my patients with inflammatory bowel disease have issues with as well. So you just have to be aware of what it can do to your GI tract.
Interesting. So we have 2 questions one is on low calcium and issues with that and how do you manage it? And another is on iron, having low iron, and how do you manage that? And are they caused by the amyloidosis? Does that stop?
Low calcium's a little bit tricky, and sometimes people end up having things that are a little bit outside of the GI tract, like they may have renal problems, kidney problems, or something like that. And so that gets a little more complicated, and we recommend calcium and vitamin D, not because of low serum calcium, but if someone has risk for osteoporosis or something, just to keep your bone health up. So if somebody has low calcium, that one's a little complicated. You probably need a little bit more workup, and may not just be dietary issues. Low iron is hard, I think. So I take care of patients with inflammatory bowel disease and amyloid, and both can lose iron from their GI tract because of ulcers or this or that, or low nutrition. A lot of times I will start if people can tolerate it with oral iron. So you can take, you can be prescribed it, or there's over-the-counter iron with vitamin C that a lot of times I'll try, but it can cause GI upset. So a lot of patients can have heartburn, or it could slow down your GI tract, and they just can't tolerate the oral iron. And if that's the case, sometimes I use iron infusions more in my inflammatory bowel disease population, but if that's appropriate and the hematologist is okay with it, sometimes you need parenteral iron or iron given through your IV to help keep your iron up.
So we have several questions around gas, bloating, and reflux. And so how do you manage those dietary changes? And what do you take to help with the gas and / bloating?
Again, I think treatment with rifaximin is the way to go. That's what I've had help the most. I think so many patients without amyloid have bloating, right? Like it's like an epidemic, right? Like many patients in the United States, and it's probably our diets, and a consequence of what we put in our food. I can't pinpoint it, but I do think this is a problem. So I really try aggressively small bowel bacterial overgrowth. Some patients do benefit from more focused diets, like the low FODMAP diet can be, and that really is pulling off things that your body would make that would be fermenting and cause a lot of bloating and a more gas producing. I don't like people to be on that long term because it can lead to some restrictive eating and things. So we sort of try it and then fold back in things. That's where the functional medicine team gets really helpful, because they do what's more of an elimination diet. So you'll kind of restrict down and then start adding foods back to help you figure out what your triggers are. Mm-hmm. So that can be really helpful as well. Making sure that you have good bowel movements are really important. Some people are like, oh, I'm not constipated, but then we really dig in and it's like, well, I do get more bloated before, my bowel movements. And so sometimes if you sort of go towards constipation, or really hard stools, like trying to keep that in the more softer area can be helpful with bloating. But bloating we don't always fix it. We control it.
So one question was interesting, is there any signs that if you have nothing else, from a GI perspective, a symptom or sign that you could look at and would suspect amyloidosis, and hopefully be able to diagnose it earlier, or is it usually diagnosed through other organs?
That's a great question. I would say most of the people who were diagnosed with sort of localized GI, it was found in a polyp or something like that. It's all over the place, but I think the GI tract has such a random array of symptoms that there's nothing I can point to that says, oh, that person's got amyloidosis. Unfortunately. So a lot of it is more the constellation around what other symptoms and what other organ systems might be affected.
And there are a couple of questions around testing. One is, how do you test for bacterial overgrowth? And the other one was, how do you test for pancreatic insufficiency?
So I frankly don't test for small bowel bacterial overgrowth. You can get it done, and there are lots of GI practices that do it. I just treat people, and if they improve, great. And if not, that's not the treatment strategy we go for. So that's my practice, and probably different than others. As far as pancreatic insufficiency, there are stool tests that you can do, and you'd need a gastroenterologist to kind of guide you through that. But there are stool tests that can be done to look for true pancreatic insufficiency.
Oh, here's a question I like. Do you recommend probiotics? I feel like this is like face cream that's being marketed to you, and you don't know whether it does anything.
Well, you're going to ask, 5 gastroenterologists and get 5 different answers, right? So this is like truly my personal opinion. And I've used them a lot. So in my patients with inflammatory bowel disease, we're so hopeful that, boy, if we could just change the bacterial milieu around with probiotics, we can affect inflammatory bowel disease. I just haven't seen it. And frankly, I haven't seen it do all that much with small bowel bacterial overgrowth either. And so, you know, a few patients, they'll try it and feel better, and if they do, great. But I haven't seen it work enough that it's something that I routinely recommend in practice. Unfortunately, I wish I had a difference.
And a couple of questions on imaging of, is there any way you can see amyloid in the GI? Somebody thought their physician had. And with any of the new imaging modalities that are even under investigation, can they image?
I think the question I would have is, you know, what's it going to change? You know, again, like we kind of talked about earlier, like I have patients who have AL who are in deep remission. I mean, years, status post stem cell, and are doing great. And we'll do their colonoscopy, take a polyp, and there's a little amyloid deposition. That doesn't mean they're not in remission. It doesn't mean that we change anything that happens to them. So to me, it's a little bit, the question is like, what would I do with that? Mm-hmm. So I don't have a great answer. So I don't think it would really change what I would do as a gastroenterologist who treats patients with amyloid.
How can I tell if nutrients are being digested properly? This is somebody who has hereditary ATTR and says has gained a lot of weight as well. Is that something? How should they know?
So if you had GI amyloidosis that was affecting your ability to absorb appropriately, you would have severe diarrhea and end up with something called protein losing enteropathy and have a lot of weight loss. So if you're gaining weight, you are absorbing the nutrients that you need in certain ways, right? And so, you know, I would not say that person has severe malnutrition from gut involvement with amyloidosis.
So here is a question that we hear quite a lot from patients, that they have alternating constipation and diarrhea. And how do you manage that?
Yes, that's really hard. And I think understanding there's a bit of expectation around this. Amyloidosis, when it affects the nerves of the gut, it can get better, but it doesn't always. And so when the nerves of the gut have been affected, sometimes they're permanently affected. And so what you used to have may not be your norm anymore. And we now need to try to help you manage what you have, which may be alternating diarrhea and constipation. And it comes down to what's going to be best for your lifestyle. Some people prefer to have multiple bowel movements per day because the feeling of constipation is so miserable. Mm-hmm. And so we sort of help them go in that direction while trying to maintain, you know, no incontinence or anything like that. Some people say, no, I'd rather not go to the bathroom or no, if I have something to do, let's, you know, think about pushing the Imodium more that day or the day before, so that I can get to where I need to go, or go on the golf course, or go to my daughter's soccer game or something like that. But it is managing what sometimes becomes the new norm, and trying to work with what's going to be best for that patient's quality of life. There's no easy answer for that one, unfortunately.
Yes, I think that's one that we hear really can impact quality of life, and is often overlooked. We get caught in other areas of, you know, we look at research, and actually these issues can have such a huge impact. It's important to.
And I forgot to mention this, but one thing that I really focus on too, and is an underlooked area, is sort of under the hood, but some patients need pelvic floor therapy. So it's an area, like, especially maybe women who've gone through childbirth, your pelvic floor is complex and trying to keep stool in or let stool out. You sometimes need someone to help you get that correct again when you have a new norm with your bowel movements. And so I mean, it feels a little uncomfortable because you're, dealing with your sphincters, but it can be really helpful. So that is something that I often talk, both for diarrhea, especially if there's incontinence, like you can't control your bowels, or you have to wear a diaper, or you need a change of clothes, or constipation. Sometimes actually that can be really helpful as well. So I wouldn't overlook that as an option.
Interesting. And we have one last question. Is there any connection between amyloidosis and hemorrhoids?
Oh. Not directly. Unfortunately, a lot of people who don't have amyloid have hemorrhoids. But I will say, if you are on the more constipated side, that's where hemorrhoids can be more likely to occur. So, just trying to do that well. Some, again, like pelvic floor therapy, if someone's really holding or they've had a lot of pain before, or fissures or something like that, sort of retraining and trying to allow stool to come out the right way can be really important.
Excellent. Thank you. This was wonderful. Thank you so much for your time today. Really informative talk, and thank you for answering so many questions. And everybody, before you leave, or as you leave, there is an exit survey that comes up, and we would love it if you take a moment to tell us how we're doing. There's also an option to give us some topics. We love to hear from you. We really want to make these ArcTalks webinars as valuable and interesting as possible. So if you have any ideas or topics that you'd like to hear, physicians that you'd like to hear from, please put those in the box. Thank you all for joining us today. We thank everybody for their support. We wouldn't be here without your support. So please also consider making donations to ARC. Thank you. Thank you, Dr. Horst. That was a wonderful talk.
Absolutely. Thank you.
Take care.